Good morning, everyone. We are all together because we think that surgery is an important part of healthcare systems. And we believe that because we have experiences. A lot of us have gone abroad and have found people who are in need for surgery, and we believe it's a big problem because a lot of us are surgeons, actually. But the importance of surgical healthcare is actually based on a belief and perceptions and not on epidemiological research right now. And that is first start of this first annual conference of the Center for Global Surgery. I can state for the first time with a big confidence that of the 1 billion people living in sub-Saharan African countries, at least 56 million people are in need for surgical care today. I hope you can grasp this figure. It's the state of California and New York together as population. They need surgical care today. And in this talk, I will tell you how I come to this figure. While thinking about my message for you, I realized actually that I don't need to do a personal doctor-patient story about an Aminata with a fungating breast mass or about a Musa with osteomyelitis, because we all have these stories with us. So right here at this conference, I want to do a business talk. I want to tell you that those people are in need, but those people are actually showing a big market. Those 56 million people, those 56 million people are giving a lot of job opportunities for healthcare personnel. It shows ministries of health and hospital managers what kind of equipment is needed to execute their profession. And it will tell suture companies and band-aid factories what their consuming market can be. And I heard Ethicon and Stryker are around, so I hope they also hear this story. Because what I've learned is that African countries are the upcoming place to invest in. They talk about striking and driving economies right now. Unfortunately, most of the mentioned companies didn't want to fund my research, so I had nothing to disclose. Other than that, surgeons overseas funded the logistics for the executions in Rwanda and Sierra Leone of SOSAS. I do have to disclose, though, that I became TED addicted to this talk. I heard that I need to do a TED talk, and I didn't know what it was, so I went on the website and looked for some. And every night now, I listen to a TED talk. And best from me are those from the African storytellers. And one compelling story comes from, her name is crazy to pronounce, Chimamanda Adichie, with the title, The Danger of a Single Story. And that story made me realize that my story here, a single story, may be dangerous as well. So I hope that I can invite more people to do this research. The acronym is the most important I learned on my talk, Browsing Time. And so it doesn't really matter where the letters come from, but it is important where it stands for. And we call it SOSAS, and it stands for Surgical Market Research. And in order to develop this survey tool, I asked a lot of input from colleagues who joined the SOS member list. We sent out an email and asked them if they wanted to contribute to the survey tool. And I think by now, or well, I was already introduced as Dutch, I'm quite cheap, so no one got funded for their contributions. They gave their comments for free. Actually, some of you are around, so thank you for their contributions. In total, 46 surgeons, residents, and students from 23 different countries around the world contributed to the survey tool. And they told me in too many emails what they wanted to be included in this survey. There was an overwhelming push to use iPads. What you see here, our enumerators are using, is correct. All of them use the iPads. And I was quite hesitant to use them. It was way too fancy for me. I had literally to go to the Apple store to get introduced to the device first itself, but got less technophobic on it and was taught how to do the programming for the survey. A medical student from Duke gave me 3 lessons for free again in the programming for it, and I must say it is really a good thing that happened to the survey. I was hesitant because it was too fancy for me. But I still have to do the real accounting, and I think actually that SOS gained on it. The initial expense was high because each enumerator needs his own device. But since there was hardly any printing cost, there was no data entry personnel needed, and we could have data downloads during our survey execution. We had a lot of profits from it and no loss. One good thing about it, using a computer device, was that we could block questions when they became irrelevant. So we wouldn't have a question of were you pregnant at that time when it was a male. There was also timestamps in it, so we could follow and track how long it took for the enumerators to do the survey, which gave us great insight. We did a pilot first, and so we could do better planning for the full country surveys. My hesitation of using with them, apart from that I was technophobic myself, was also that I thought, okay, I have to work with enumerators in African countries, and some of them never have ever used such a device or not even seen a computer work with it. But it appeared that a 1 week of training with good field supervision was actually enough. So it was actually really fun for the enumerators as well to work with. But let me go back to the actual survey. The survey consists of 3 parts. The first part is an interview with a household representative, and it asks about the household denominator, so how many people are in the household, their ages, and then it asks about how many people died in the last year. It tries to figure out if there were surgical conditions with these people. And it asked about how do you get to your healthcare, how do you get to the primary healthcare, the secondary healthcare, the tertiary healthcare if you need specialized care. So there's a lot of information coming out of it. I sort of feel that I created a monster with it. I'm still working with the results. The second and third part are identical, and is for 2 household members randomly selected to be interviewed in depth on their surgical history. And we grouped most of the surgical conditions so that a lay person can understand. So it is about wounds, masses, swellings, congenital deformities. So basically, you're born with the problem, or acquired deformities. And during the pre-testing of the survey, we found that questions about the surgical conditions grouped in anatomical locations gave better recall. So we grouped the different anatomical locations in head, face, neck, chest, breast, back, abdomen, groin, and extremities. And life is made very easy for the enumerators because they could just start asking, oh, did you ever have a problem with your chest, breast? Really no problem, okay, so no wound, no masses, and then it would block all the in-depth questions which would otherwise be asked. If they did have a problem, a surgical problem, so a wound, a mass, a burn, more questions were asked regarding the start of it, if it was still present, if it was injury related, and what was the injury caused by. There's also more questions on health-seeking behavior. So did they look for it? What did they receive? And if they didn't get any surgical care, why was that? And one of the answer options is that there was no need for it. And this can exclude, in our estimation, that excludes the people who will not look for healthcare anyhow because they think it's not needed, or who did look for healthcare, but the medical doctor or the nurse said that there's no need for healthcare. So you can understand that this figure I just showed of 56 million people in need for surgical care today, with the condition today, that it is probably an underestimation what is really needed. Our categories of wounds and masses and deformities and swellings do have some problems because, for example, in case of deformity of the maxilla based on a Burkitt's lymphoma, you don't really need to cut it out. You don't need a surgeon for that. So it will not give a precise figure on surgical conditions. However, because a lot of surgical conditions don't have symptoms, I think that we still are talking about an underestimation. The discussions on the survey methodology were held with survey experts from the UVA and with Statistics Sierra Leone and the equivalent in Rwanda. And it was decided that it was most beneficial to do a random 2-state cluster household survey, stratified for district and for rural and urban areas. And then randomly selecting with the probability proportional to population size. And what this statistical talk basically means is that we want to have a a representative sample of the population. So here you see the clusters we took in Sierra Leone. We had 75 clusters. In each cluster we went to 25 households, and in each household we had 2 people to be interviewed in depth, which gave us a total figure of a little less than 4,000 individuals we have interviewed. The sample size calculation was based on a pilot study we did earlier in Sierra Leone, and that gave a figure of 7.3% of the population we interviewed was having a surgical condition and needed care for that. I would like to stress the usefulness of a pilot study, and also to do the pilot study first and do the full country survey a couple of months later. Because a pilot study can really give you a lot of insights, gives you a lot of connections to local knowledge, and it gives you practically also the response rate of the country, the enumerated quality, which you need to know before you start planning for your full country survey. Actually, survey experts Sudman and Brandburn have clearly stated this with, if you don't have the resources for a pilot study, you should not do the study. And although the cluster sampling gives us an easier sampling with less traveling than simple random sampling of like those 4,000 individuals, still a lot of traveling is the case in a lot of sub-Saharan countries. And I've indicated on this map the main roads, or the roads as main roads, but actually a lot of them are still dirt roads and difficult to access. So we can imagine that there were flat tires, hours of walking for enumerators. Some needed to go by boat, and there were a couple of mudslides. And to give you the full story with this one, the first thing people shouted at her was, "Watch out for the iPad." So they were very engaged in that. But mudslides were not the main problem. The people had a lot of problems with estimating the age of all the household members. And so we gave them the developing stones for the children, and then also an event calendar of Sierra Leone, which like told them, okay, were you there when this big famine happened, or were you there? So they could estimate the ages of the people. Another big problem was the random assignment of the 2 individuals, because everyone wanted to be interviewed, especially the chief of the village wanted to be interviewed, and the people who had something wanted to be interviewed. So they had to really explain, okay, no, it's a random sample, the computer is telling us what we need. So we had a random calculator on the iPad, and actually one of the enumerators, after she did her listing for the household, she said, okay, the household representative, you push the button. Then you can see that it's not me who is choosing who to interview. I thought it was really a nice way of doing it. So our enumerators really were engaged in doing it the right way. I was really amazed how they wanted to do it good. I thought they would try to be the quickest we had 4 different teams, so I thought, okay, maybe they want to find to be the quickest back to the capital, but actually they were calling with each other, oh, Reinou says our data quality is better than yours. So they were really trying, which gives me great confidence on the figure I give you. SOSAS is designed to be used in multiple locations, and as I said, we are now looking to the results of Rwanda and Sierra Leone alone, and other countries have shown interest, and I'm happy to talk with any one of you who would like to know more about it in depth for their own country of interest. But iPads don't need to be a limitation of it. I have a paper survey as well. It's actually on the internet, and so iPad should not be seen as a limitation, although it has a lot of profits. And I want to stress again, a pilot is actually a need before you start doing the full country survey. Because of the medical nature of questions, we used nurses and medical students. And actually some survey experts say that you shouldn't use medical personnel because they're not impartial enough. And the only thing we can find out is if someone stands up and wants to do it without medical personnel, and then we can see if that makes actually a difference. But so that might influence my results a little bit. And the other limitation is that some of our conditions may be misclassified as we see it as medical persons, because we really have a community perspective of a wound or a mass. Maybe we see it clearly as a breast cancer, but that person says, oh, I just have a simple wound. So you don't know what they perceive, and more, I hope that more in-depth research will be done also on that part. So this is the background I wanted to give you to this figure on epidemiological research, and stressing that this is actually a lower estimate of the people in sub-Saharan Africa who need surgery today. And I hope that this will not stay a single estimate and a single story and become dangerous, but that more people will follow and will do the same survey. And I believe that SOSAS can play a major role in that. But as final remark, I want to stress that I hope actually that questions on surgical issues will be engaged in the demographic health surveys, which are done on a regular basis, because I think that really shows that surgery is part of healthcare system and it's an important part of healthcare system. So thank you.